Mrittika Sen. Dr. Mrittika Sen did her MD from AIMS and fellowship with Dr. Santosh Onava sir and Carol Shields from Philadelphia. Presently, she is working at Shankar Nethralaya, Chennai, and she will be talking about the retinal tumors to be worried about. Over to Dr. Mrittika.
Good morning, everyone, and thank you, Dr. Sumit, for including me in this IC. Dr. Sonal has already explained to you the lesions that you need not worry too much about, and I'll continue with the lesions that you need to worry about. There are some pictures which may be similar because we all come from the same family of Dr. Honavar, so we have the same source. All right, so I'll be taking you through the retinal lesions which you need to actually worry about. So choroidal nevus, we don't see them too often in our population, but when we do, we need to identify the ones that are at a risk of transformation into a melanoma. So how do we decide that? Although the risk is quite low, there are certain typical features that can help us identify the risk of a transformation, and that is with the help of a mnemonic which goes by TFSOM DIM, and I'll explain that in the next slide. Also, nevi, they can grow, but it is the rate of growth that is important. Not every growth represents a malignant transformation. So coming to the mnemonic, it basically correlates the clinical features with the imaging features that can help you identify. So a thickness of more than 2 millimeter, that is on ultrasound, presence of subretinal fluid underneath or rather overlying or around the lesion, that is on OCT, visual acuity less than 20/50, presence of orange pigmentation, this is best appreciated on autofluorescence, and this is because of the presence of lipofuscin. And presence of melanoma hollow, that is again an ultrasound feature, and on fundus photography a diameter greater than 5 millimeter. So presence of 3 or more of these features puts this patient at a relatively higher risk, and you would want to treat these lesions early. So this is a slide that kind of shows you the difference between a nevus and a small melanoma. If you look at this lesion, this is a relatively flat lesion. Of course, we will confirm that on ultrasound. But these lesions on top, these are drusens. Presence of drusens are basically indicative of a chronic lesion. On the other hand, when we look at this one, you can see the extensive amount of orange pigmentation that is overlying this lesion. In addition, you have a nodular component with a slightly greater thickness and most likely SRF associated with it. When we do an OCT, we are likely to find some amount of SRF. So this is a lesion that I would treat, and this I can keep under observation. So this is a small melanoma. Again, part of it can be pigmented, a part of it can be non-pigmented. On autofluorescence, the orange pigmentation is better defined, and there is subretinal fluid which also contributes to the poor vision. So in this case, this patient has 4 of the risk factors. So we would treat this lesion. Again, it is a combination of these factors. So when we have 4 or more features, as you can see that the risk of transformation into a melanoma is almost 50%. So this mnemonic or these imaging features are helpful in diagnosing small lesions or small melanoma. Of course, the larger ones, there is no doubt that it is a melanoma. So it's only for the small lesions where you have some doubt whether to observe or to treat that this comes into picture. Now I'll just take you through some of the pictures that show some of the manifestations or the presentations of choroidal melanoma. It can be a very small one like in this case. On the other hand, it can be large with overlying hemorrhage, or it can have a ciliary body component as well. This is the most common form where you have a large pigmented choroidal mass. Sometimes they can be amelanotic, in which case you can confuse them with a choroidal granuloma or a metastasis. As I said, that they can be a component which is pigmented and a component which is non-pigmented. Similarly, you can have lesions which can show a break through the Bruch's membrane, and that is because of the and that can show a collar button or a mushroom appearance. Now, the important thing to remember in this case is when we treat them, we should remember that the base is always larger than the lesion that is visible as the mushroom shaped within the eye. So we have to treat the entire base, and that is apparent on ultrasound. So we have to take the ultrasound measurement. And this can also have vitreous hemorrhage, which can actually preclude our view of the lesion. So here again, imaging plays an important role. So this is a hemangioblastoma. Why am I showing you this picture? Because you can see these dilated tortuous vessels, and so a hemangioblastoma will have a dilated feeder artery and a dilated tortuous draining vein. On the other hand, whenever we see a tortuous vessel, we should examine the periphery very carefully, because it can also harbor a melanoma at the periphery. So just like a sentinel vessel on the surface of the eye, where we always tell you to do a gonioscopy or a UBM, it's very important to indent and look for peripheral lesions. In case of melanoma, there won't be a feeder artery, but generally what is observed is just the dilated tortuous draining vein. Another type is the diffuse choroidal melanoma. These have large segments of pigmentation, and these tend to be rather extensive or rather aggressive, both moving extrasclerally as well as with their metastatic potential. They're not very thick, but you can see the extensive amount of orange pigmentation that is